So we will go through a couple of instances of HIV medication use in special populations. This is testable material, so do be sure that you've read through this and kind of understand where I'm coming from. In this section, we're going to talk briefly about the use in pregnancy to prevent mother-to-child transmission. We'll also talk about the use of these medications in newborns. And in the last section, we'll talk about pre- and post-exposure prophylaxis. So first, again, as a recap, what drugs should we avoid in women of childbearing potential? Efavirenz, the NNRTI that causes neural tube defects in the first trimester, should be avoided in people who might potentially become pregnant. And dolutegravir, the integrase inhibitor, should also potentially be avoided because of the neural tube defects in the first trimester. What I will say about dolutegravir is that we have to remember that most of the studies that have been done that show an issue with neural tube defects were done in other parts of the world, less developed parts of the world, and mainly in sub-Saharan Africa. There are many reasons that a person living in sub-Saharan Africa might give birth to a child that has neural tube defects, and one of the biggest concerns is the lack of supplementation of folic acid, which we do on a regular basis in the United States, but it is something to bear in mind that we don't necessarily know if it was the medication or not, but until we know more, we definitely want to stay away from a medication that might cause infant abnormalities. So if a woman is pregnant and she was on efavirenz before she found out she had a positive pregnancy test, the question always comes up, is it worth stopping the medication and starting a new regimen? And my answer to that would be that no, it is not, because we need to consider when the teratogenicity has occurred. And the risk is usually in the first trimester, and most people are just about done with their first trimester before they find out they're pregnant. We also need to consider that if we start a person on a new regimen, that new regimen will potentially have new side effects, which might make it very difficult for the patient to adhere to the medicines. And we need to consider how that non-adherence could impact the fetus's risk of transmission. And if she is undetectable and she's on an efavirenz containing regimen, my guess is, and most people would suggest, that if it's not broke, don't fix it, just leave her on it at this point. But with dolutegravir, if a woman is pregnant and she was taking dolutegravir, the same question could be asked. And what I would say is that maybe it is worth stopping it. And the reason I would say that maybe it is worth stopping is because we again have to consider that in the third trimester, women have a much higher volume of distribution, and you would need to take higher amounts of the drug to keep the same level in the system. So at that point, it might be worth changing the drug over. That's not the case with efavirenz. So in pregnancy, a number of trials have been done to support the efficacy of these medications at preventing transmission to the child. And all the studies that have been done suggest that a combination is much more effective than using a single dose. This is always considered as part of a three-drug or a three-part strategy. And what I will suggest is that we will talk about what happens to the mother before birth, what happens during the delivery and intrapartum, and then what we give the infant after the newborn has been born. New medications haven't been tested well in pregnancy, so we need to consider that our recommendations are going to be different in non-pregnant adults than they are in pregnant adults. And the one kind of key bit of information I want everybody to be aware of is that in resource-rich countries, especially in the United States, the treatment during pregnancy and having gone through successfully antenatal, intrapartum, and infant prophylaxis is going to reduce the likelihood of a transmission to the child by less than 2%, or to less than 2%. And in New York, it's actually less than 1% right now. And this is going to require that the mother have an undetectable viral load throughout her pregnancy. Early initiation is associated with better outcomes, so the sooner we can get her on a medication that is appropriate or a medication regimen that is appropriate, the better the chance that it's going to be effective. The one thing I will say about this, though, is that when you're talking about somebody who has never been on medications before, was newly diagnosed during pregnancy, some people would suggest waiting until the second trimester because there is still some concern that these medications might have long-term effects on the development of the child. Most of that has been kind of proven not to be true, but for those who are concerned, they may wait till the second trimester. So some questions about how you would handle a situation if a woman was pregnant. If she was on combination antiretroviral therapy and she was suppressed, we're going to continue the therapy. If it's not broke, we don't want to fix it. If she's on the cART and she's not suppressed, we want to assess the reasons that she is non-adherent or that she has a viral load, including drug interactions, get a resistance test, and then switch accordingly. And then for somebody who's treatment experienced but has stopped taking antiretroviral therapy for her own reasons related to non-adherence, we then are going to get a resistance test and choose the regimen accordingly as well. There are preferred regimens in somebody who is now newly diagnosed during pregnancy. And just like with our non-pregnant adults, it's going to be 2 NRTIs with either an integrase inhibitor or a boosted protease inhibitor as the third agent. In this case, though, there are some differences that are worth mentioning. One is that there is limited data about the use of tenofovir alafenamide in pregnancy, so it's not recommended currently. So you have the choice between tenofovir disoproxil fumarate with emtricitabine or abacavir with lamivudine. Some concerns that have arisen are that we do know that there's some issues with bone mineral density and tenofovir disoproxil fumarate. So the question is, should we be using this in women while the baby is developing its bones inside the mother? So far, data would suggest that during pregnancy, there is no adverse outcome of using tenofovir disoproxil fumarate in a pregnant woman. Of integrase inhibitors, the one that's actually of choice here is one that is not used in our non-pregnant adults. It's raltegravir. The reason is that there's a lot of data suggesting its use, but we do need to consider that the twice daily is the only option in this patient. But this does avoid drug interactions and side effects. And of ritonavir boosted protease inhibitors, there are 2 that are available. The drug of choice is actually atazanavir, ritonavir. So one thing to keep in mind is that darunavir is not the drug of choice in pregnant women. Also, cobicistat is not used in pregnant women, so it has to be dosed with ritonavir. The dose may need to be required in the 2nd or 3rd trimesters, but it still is only once a day. But if you were to try and use darunavir in a pregnant woman, it's got to be used twice daily. So intrapartum management in women who are coming in with their water having broken and their viral load is less than 1,000 copies, you can continue with the vaginal delivery. During the delivery, there is no specified need for IV zidovudine. It doesn't appear to further increase the risk or reduce the risk, so most people will go through delivery with no problem at all. In those people who are high viral loads right up through the end of their pregnancy, we recommend a cesarean section at 38 weeks, which is pre-labor. This is going to reduce the risk of the child and reduce their exposure to the body fluids that they would be exposed to in a vaginal delivery. In this case, IV zidovudine is recommended to be given to the pregnant woman, even if she was taking antiretroviral therapy. And this is started 3 hours prior to the C-section and continued until the delivery is over. So in infants, we need to consider what we would do after the infant has been born as the third part of our treatment strategy. It's initiated as soon as possible after delivery. So usually within 6 to 12 hours, somebody has given this baby their first dose of antiretrovirals. In mothers who have been suppressed and have a viral load less than 1,000 copies, you're going to give the baby 4 weeks of zidovudine prophylaxis. If there was any issue or concern that they weren't fully suppressed throughout their pregnancy, you might increase that to 6 weeks. But for the most part, zidovudine by itself is effective. And mothers who were not suppressed or had a viral load greater than 100,000 copies are given doses of zidovudine, lamivudine, and nevirapine for their infant. Those that are in higher risk, which would be anybody who's got a viral load greater than 100 or 1,000 copies, is given daily lamivudine, daily zidovudine, and prophylactic doses of nevirapine at 48 hours after birth, 48 hours after the first dose, and 96 hours after the second dose. And if somebody's considered at a very high risk, like their mother had not been on antiretrovirals throughout the entire pregnancy, either didn't know they were HIV infected or decided they didn't care, then nevirapine is also used daily, and these are also used for 6 weeks. There's a lot of data suggesting that raltegravir might be an option in some of these patients, and it looks like it may soon take the place of nevirapine as a preferred regimen, especially for those in the highest risk categories. But right now, we're still using nevirapine as our option. And all of these drugs in infants are based on weight, but also on the number of weeks gestation at birth, which is way beyond the scope of this class, so we won't worry about that. So then the question comes up, well, how do you test the infant for HIV? Most of the time, we're dealing with a mother who has been tested, and we kind of know her status, so we're going to test the infant just to be sure. If we were to do a serologic test, which is how we do testing in adults, we would be testing for antibodies. And if we do a serologic test in a baby, the test is going to come up positive for the mother's antibodies. So one question that comes up is, well, as of 1997, all newborns are tested for HIV, regardless of whether the mother says yes or no. So we're going to find out the mother's HIV status anyway. But how do we do a test in somebody if we're not doing an antibody test? And the answer is that we use a viral load test instead. So for people at high risk, for newborns at high risk, we do an HIV test at birth. We do one at 14 to 21 days. We do one at 2 months, and then we'll do another one at 4 to 6 months. And for those at low risk, and again, this is the cutoff between 1,000 and less than 1,000 in terms of viral load. For low risk, we're doing 14 to 21 days, 2 months, and then 4 to 6 months. And some clinicians will actually recommend that at 18 months of age, when the infant has been around for a while and has cleared the mother's antibodies, we would do an antibody test just to confirm the child's status. So what about breastfeeding in our HIV positive women? We know from pathophysiology that breast milk is a fluid that contains the virus. So it's not recommended that women, even if they are undetectable, will breastfeed their children. And this is based simply on the availability and the affordability and the safety of replacement feeding or formulas. So one concern is that even outside of the virus, there is the possibility that the drug can be secreted in the breast milk, and we don't necessarily know what the risk of toxicity to the fetus is. But we do need to consider, too, that we are in a situation where we're in a developed country that has access to clean and safe water. But in parts of the world where that isn't the case, in resource-limited areas, there may be benefits to breastfeeding in these areas. So the benefits are you are increasing the exposure to the mother's antibodies, which keeps the child safe. And also, not using formula is a good thing because most often formula requires water to be reconstituted, and the water may not necessarily be safe. So it's worth considering that in other parts of the world, they may be breastfeeding, but not in the United States.